attending our first advocacy event post-COVID, and we are so thrilled to actually be in a room with one another. Yay. And for those of you at home, thank you for joining us and watching our YouTube premiere or watching us on our YouTube channel after the fact. And we hope that all of you, both in person and online, will be able to get so much from this meeting. We're thrilled to be here, and we really wanted to focus on getting the care that you need. And so before we get into some of the hurdles that we're going to go through, the first thing we're going to start out the day is we're going to hear from Dr. Eric Shaw. Dr. Eric Shaw is a gastroenterologist at Dartmouth. He not only runs the esophageal motility lab, he has also been a dear friend to IFFGD, and many of you have probably seen his talks through our various programs or fact sheets that he has written for us. We're thrilled to have him here to kick us off today to really talk about how to appropriately communicate with your provider so they can really truly set the right stage, both when you are in the doctor's office and then even before you get there, and what to do afterwards. So we have two speakers up this morning, and we're going to be focusing on that doctor-patient relationship and how that can help you get the care that you need. And then later this afternoon, we'll be talking more about making sure that you can afford to get the testing that is ordered, to see the doctors that you need to see, and then the medications that might help you in the long run. And how can we navigate the system, the complex system of insurance companies and denials and insurance plans and all of that. And so we'll be talking about that this afternoon, and a little bit about how we can work in Washington to get some legislation passed so that these barriers might not be so high moving forward. And then, of course, tomorrow we'll be taking this group in person to the Hill. We'll be visiting with congressional offices tomorrow all day, talking about our stories, talking about what we've been through to be able to be where we are today, and what are the needs of the illness community. And for those of you at home that sent in your stories who couldn't be with us on the Hill tomorrow, thank you so much. And remember, advocacy just doesn't happen in the 2 days that we are here in Washington. It's 365 days a year. So if you'd like to take part, if you'd like to learn more or learn how you can communicate with your legislative offices, please contact us at iffgd@iffgd.org, because we're all in this together, and it's going to take all of us to make some difference. So before I welcome Dr. Shaw to the stage, who we're so thrilled to have with us today, I want to take a time to thank all of you in the room for actually making time in your schedules and flying out here. And I know that with the hurricane, there were some issues, not only for the IFFGD team, but for some of our guests as well, and we really appreciate your diligence in getting here. We also would be remiss not to thank the wonderful supporters of the program who made this possible. Without the help of Takeda Pharmaceuticals, Ardelyx Pharmaceuticals, Pfizer, and Vanda, we would not be here today because we would not have the funds to be able to bring all of us into this room and be able to create these programs. So we thank them. And of course, the wonderful staff of IFFGD who has worked tirelessly the last few months in order to have this program take off, especially Haley McCorkle, who is our project manager, who unfortunately had an incident and wasn't able to join us, but she has been in direct communication with us constantly to make sure that we are on our toes and that this event is going to go well. So we thank Haley, and then of course most of you know Jamie Dumont, our director of operations, and Alyssa Sutton, who are all here today. So, and Megan Che also was unable to join at the last minute. Again, another person who had an issue coming today, but that's okay, because we're here, and we're going to make it a great 2 days. Throughout the program, we are going to have talks, and then we're going to have discussion. And so we really invite those of you in the room to really contribute to this discussion. We want to hear your stories, we want to hear your thoughts, your comments, your advice to those who are at home, so that we can ensure that we're having a well-rounded program this weekend. So please be active, and please contribute to those discussions. So, without further ado, Dr. Shaw. let's kick off this program.
Well, this is very timely. We're going to be discussing the patient-provider portal. Okay. And while this isn't medical advice, it is advice from legislators, actually. And we're going to be discussing what the legislators have set up not that far away from where we are right now and what we face and finding common ground. So what is the purpose of the patient portal? It anchors on communication. Communication is critical to high-quality care, and we know that in any relationship, communication, it always takes two. So what it does is it provides a forum for interactive communication and coaching, meaning after the patient and the provider have a visit in the office, there might be some questions. So why not offer a way for some of these questions to get answered where it may not require another follow-up visit? Something that's quick, something that reinforces what we on either side might have forgotten, because we cover so much information during office visits on all sides. And so what these portals are intended to do is, by increasing communication, is increase trust. Trust in who? Trust in care. Right? Trust in care to get the thing accomplished, which is better health. Sometimes decrease costs. We're going to be talking about costs later today, and costs are very important. Here it might be one less office visit. It might be getting to that treatment faster, whatever it is. So that's the purpose of how this was designed. How does the patient portal work? Well, the patient will access the portal and send a message to their physician, right? Maybe not. So what if it's actually that the nurse might catch that message and then respond back to the patient? The patient is going to then send a message back to the nurse, who's going to go back to scheduling, is going to go back to the patient. Physician's nowhere in this, right? And I think this is something that the medical offices see day to day, our patients see day to day, our nurses and our schedulers see day to day. And what's interesting about all of this is everyone on this slide is a patient too. So the intended purpose of these portals initially was to help patients manage their own health information. All the medical information that patients have belongs to the patients. And it allows for communication with the team at the start, as it is right now for pharmacy refills. No longer does someone have to wait on hold for that. You can access that, request a pharmacy refill. And that's built into legislation, that these systems are supposed to be able to allow these things. Appointment requests. Why not be able to access an electronic portal and self-schedule on your own? Outside of healthcare, you can do this in any other facet, whether it's airlines, hotels, anything else. Why can't you do this at your doctor's office too? Simple questions, and we're going to get to what simple questions actually mean. So this is all on healthit.gov, which is the government's website that helps to describe what these portals were intended for when they were created. So they did not intend it to replace a clinic appointment, complex medical needs, major medical decisions, new or emergent concerns. And the reason is, would we trust seeing a healthcare provider over Twitter, essentially? No, there's going to be a lot that might be lost in that communication. How many have written an email that takes 20 minutes to write, is one sentence long, and might not be heard by the other side in the way it was intended? So it doesn't completely replace what that full office visit, that face-to-face encounter is supposed to accomplish. What ends up happening is it turns into a competition. Right? And who's on that other side? It's the patient versus the physician, patient versus the provider versus the nurse versus the physician or the scheduling secretary or anybody. And it's all artificial. So moving from competition to collaboration takes a little bit of understanding, I think, from what the original intent was on these systems. So what they have right now for what they recommend for these is using them to keep the message short and simple, picking a single topic. This is the thing that I really want to get accomplished, being direct, using that subject line. So if my message is going along with a lot of other messages, I want to make sure it gets to that one right person and that it gets handled and that my question gets addressed. And I want to set expectations for the response. So is this the right forum to really be getting that question addressed? And if the question isn't really getting addressed, I wonder if that forum maybe is the right one, or maybe it isn't. Maybe that takes another form of communication beyond what the patient portal allows us to do. Switching gears, and this is important. There are 3 questions that are recommended by the healthit.gov website for patients to ask their providers. First, can I send messages to my provider in my native language? So communication takes shared understanding. What the 2 sides might think they're understanding may not actually be what was intended, and so that first question is key. If I can't send a message in my native language, is there a translation service available that can help, and how accurate is that service going to be? And then third, does the portal at all have any materials that are available in my native language? So this is increasingly key. They have an example of a patient portal here where it's clear that the patient could have an option to log in the language that the patient needs. So unintended consequences of patient portals. So now, as of 2 years ago, now patients have immediate access to health information, often before the providers do. And in there is medical jargon, but this jargon can actually be very useful for providers to communicate quickly based on what that jargon actually means to them. But what the jargon means to the physician or the nurse can be very different from what that means when it's just read. And so, this is coming to the forefront now as an issue in perhaps is the jargon correct, does it need to be amended, or in some cases should it not? And there's no yes or no answer there. Seeing the results before the provider does leads to a lot of questions, making sense of complex results. CAT scans, imaging, x-rays, endoscopic tests, lab values often have multiple lines of information contained within them. What's that one important piece of information that led the physician or their care provider to order that test? What's the patient seeing when they read a line that's concerning to them? So these are questions right now about what the portal is intended to do, and is it actually accomplishing for patients and providers that better healthcare that we're all seeking. So the benefits of the patient portal, and there are data on this. This is a study that was done about 20 years ago that came up with a framework. And it starts with the idea that we all want a shared understanding of what the care is that's being delivered and how that's benefiting the patient. Recall is an issue. Recall means that so much has gone on in the office visit. A lot of information, a lot of needs are discussed. And recalling all of that is challenging. And so what the patient portal does is it allows for a direct place for patients and providers to go back over information and figure out what are the things that we're missing that I need some clarity on. When that can be accomplished, there's better treatment satisfaction, leading to better adherence. Now, adherence is kind of a weird word because it ends up labeling adherence versus non-adherence. And that really isn't it. Not at all. So rather than adherence, it might be engagement on both sides. So there might be another better word for that than adherence. I don't like that word. Sharing access with caregivers. So unintended consequences of having on or off patient portal access. There's a perceived loss of control over medical decision making. This happens both to our younger patients, teenagers, kids, parental access, and then caregiver access for adults that can't take care of themselves or their own fully, and they need a caregiver that's involved in their care. So is all or none access the answer there? And no. So this was a study that was published 7 years ago now that's also contained within the healthit.gov website. Just has a lot of information on it. And what is advocated is that sharing should ultimately benefit the patient. It's not about the caregiver, it's about the patient. There isn't a one-size-fits-all approach. And so ideally, these patient portals should be moving towards recognizing varying levels of control based on the patient's needs. How that can be accomplished and to what degree and it takes a lot of clarity, both in data but also in patient stories, in going to the Hill. So a lot of this goes back to what happens on the Hill to help get this across. So takeaways, and this talk is intended to generate more questions than answers. And that's because a lot of these technologies are so new, and they're so new in healthcare, and there are a lot of differences in patient needs, how the provider and medical practices are set up. There's not going to be one right answer, and that's exactly it. Maybe there shouldn't be. So how do you create a system that everyone's going to be able to benefit from? So the patient portal as it's designed today is just one way to communicate with care teams. For now, it's intended for simple questions, things that already exist that can be clarified. And it's definitely a way for patients to have control over their own health information. Behind the scenes on the provider side, these systems are incredibly useful for two reasons. First, it helps patients avoid that extra copay, the extra office visit or waiting on hold for 30 minutes when they can go in, log in, and request a refill. That's new. That's having a patient portal to do that is very new, and this is definitely a win that should be recognized. The other is that it helps identify themes in medical practices. When there are problems coming up over and over, that's a systems level issue that takes systems level change in the medical practice. So why is the same message coming up from patients over and over and over? Is there something that the providers and administrators can do in the practices so that maybe that problem gets solved? And so having a patient portal gives some data for the practices to help solve problems, for sure. Such as healthcare costs, and this is what's going to be discussed at the next hour. So, once a patient and the provider sort of figure out and navigate what the right treatment is going to be, well, someone has to go to the pharmacy, pick up that prescription. What about when it's not covered? Common theme that comes up on patient portals. Prior authorizations come through electronic records now. A lot of these are electronic, and they go to the provider's offices behind the scenes. And so it comes up. These are the things that may not get discussed, and there are data on this published in the Annals of Internal Medicine, a big medical journal for the internal medicine, one of the internal medicine professional societies, the ACP. It's the big one. And the discussion of costs doesn't happen. So are providers comfortable having that discussion? Are patients comfortable bringing up questions of costs and how in a visit? So there's money, right? Money's the obvious one. What about time? Time's that thing money can't buy. Time is the thing that everybody wants. That's quality of life. And time away from what? And that's however patients define that. And there's others' time, so caregivers' time, family, loved ones, work, everything that goes into life and fulfillment, and the expenses associated with that. So where do you get information about costs? Well, the doctor, all right. How much information are the doctors, the physicians, the care providers, our physician associates, and our nurse practitioner teams? How much are they capable of? How much do they know right now at a systems level? Our nurses and support staff in general take a lot of these questions, and so they might be armed with more information. Where are our social workers? These are highly trained individuals and professionals, often with master's degrees. Why aren't they in primary care offices, and what can be done about that? And of course, there's GoodRx, there are patient assistance programs, and there are many different individual ways. So are there ways to combine a lot of these so that instead of having 20 different resources that you have to know the exact one you need, could these be collected in some organized way? And so I think that the event tomorrow on the Hill is very important to try to get at some of these questions, to figure out are there ways to enact better systems level change so that everybody wins at the end of the day, especially our patients. Thank you.
actually really appreciate that and learning a little bit more about communication. However, we're going to talk a little bit in the next talk, which switches gears to when you're actually working with your healthcare provider and you're actually in the room, and maybe you want to have a discussion with them about a specific diagnostic test that you're interested in, or maybe a treatment you want to try, or they want you to try a treatment that you're not uncomfortable with. Those are difficult conversations, but there are great ways that you can navigate those types of difficult discussions with your healthcare provider. And so we were really lucky to have Jill Dush.
Hello, and thanks so much for joining us today. My name is Jill Deutsch. I'm an assistant professor of medicine in the section of digestive diseases at Yale School of Medicine, and I am joined today by Dr. Alexandra Fuss, who is our GI psychologist, also here at the Yale School of Medicine. We are speaking today on asserting your needs. So first of all, I just want to thank the IFFGD for putting on this wonderful platform and asking us to speak with you today. What we'll be talking about is how to help provide the patient's and provider's perspective on how to ask for a test or treatment which you as a patient prefer, or to decline one that you don't feel comfortable with in a way so that your healthcare provider may be able to accept it. So Dr. Fuss and I will sort of be going back and forth throughout the 20 minutes that we're going to spend together, providing some information and tips and tricks for our patients from Dr. Fuss's perspective as a psychologist, and from my perspective as the medical doctor here in the room. We'll also discuss some helpful communication tips when speaking with your healthcare provider. So with that, we are just going to begin by acknowledging the power in the room, and I will turn it over to Dr. Fuss.
Sure, thank you. So when we're in the room with a provider, there is a power differential that is present in the room, with the physician being an expert in physiology and holding that power as they are the one who decides if they're going to order a test, a treatment, a procedure. And as a result of this power differential, patients can often feel like you're not in a position to really advocate or question the providers because they have that power. And so engaging in self-advocacy as a patient can often bring up these feelings of being intimidated or feeling a little concerning. It's a little bit scary, having some worries, things like that. And so, but really this is a team sport. So what we want to be accomplishing is working alongside your provider as they are the expert in medicine, but you are also an expert in terms of what your experience is, in terms of the symptoms, what your body does, your body itself, and just the reactions to all these things that are going on. And by working together, bringing both of your expertises into this room, you get to be on the same team against the problem.
Absolutely. I couldn't have said it better myself. I think the way that I approach that power differential is I definitely start off by telling people, sure, I've gone to school for this, I've trained in GI, but I haven't lived in your body for nearly as long as you have, right, if at all. And so while I may be the expert in some of the GI related care, you certainly are the expert in your lived experience. And if you're telling me that something doesn't feel right, then something doesn't feel right. But really, I totally agree with that team sport perspective that we have to work together towards understanding whether it's something pathologic that's causing things not to feel right, or if it's something, for example, that really is in the spectrum of normal that just wasn't normal for you before. So sometimes that means prescriptive therapies, and sometimes that means realigning our goals and expectations to continue to actually work together towards improving the way that you feel.
Mm-hmm. Yeah, and so when talking in general, just human to human, there's a couple of different communication styles that folks will often lean into. So some that are a little bit less effective, but are often used are aggressive communication styles, which I'm sure we've all experienced in some way, shape, or form, or have committed in some way, shape, or form. This tends to look very direct, but also pretty rude. The message overall becomes lost because the person who is receiving that message often feels that they're being threatened. It can be very intimidating. And aggressive communication tends to elicit this reaction of defensiveness. On the complete other end of the spectrum is passive communication, though. And so in this case, the speaker doesn't really directly state what their needs or their concerns are. The person who's listening or the receiver of that message really isn't clear about what's being asked, or maybe they're just completely unaware that something is trying to be communicated. And a lot of the times, passive communication happens when somebody is trying to be polite or avoid potential conflict.
Again, spot on, right? As the provider or as the medical provider here, I think we are trained to be direct and to sort of tell it as it is. But that can, again, often be perceived much like the aggressive side of communication, right? Where patients may hear frustration if things don't align, or may hear sort of a paternalistic perspective on how we practice medicine. And that's really not our goal here. Again, we want to be on the same page, be unified together on the same team towards making things better. And so as providers, some of the things that we may be able to pick up on towards improving that communication is the nonverbals in the room as well, right? So things like movement of the body, fidgeting of hands, eye communication and how we make connections there with our visuals, and emotional cues as well, which unfortunately as providers, sometimes we're not that great at picking up on, right? So just bringing that into the topic of assertive communication, and I'll let Dr. Cruz chime in one more time, we're really good at this as providers. This is what we've been taught and trained to do, to tell it how it is. But sometimes, like I said, that doesn't quite come off the right way. And so much in the same way for providers, we don't want to necessarily be aggressive. We want to ask our patients to be assertive in what they really truly need.
Yes, and that's a great point. A lot of the times, assertive and aggressive can blend into each other. So we might be thinking we're trying to be assertive, but really it's coming off more as aggressive. So in general, though, assertive communication is this way of communicating. It's honest, you're being appropriate, and you're still being respectful, but you're also being direct. So there's really no wiggle room. There's no unclear messages being sent about what your needs are or what the point of this message is. So you get to clearly state exactly what you need, and that message gets across. And the person who's listening or taking in that message is able to hear it without feeling defensive. So just some tips for how to even, oh, go ahead.
Tips for assertive communication, right?
Yes,
so whether coming from your patient or your provider, keeping your voice calm and even, trying to avoid the frustration and the upset that you sometimes may feel that leads to aggressive communication, as we said, walking that fine line. But when one becomes aggressive, oftentimes the other becomes aggressive. And then we wind up in this self-fulfilling prophecy where nobody really gets to the place that they would like to be. And everyone walks away from a visit just not feeling good about it. As we said, making eye contact, very important, and picking up on those nonverbal cues. And, being assertive and asking for what you feel like you need doesn't always mean that you will get what you ask for. The idea, though, is to communicate clearly and effectively.
Absolutely. And just to echo that too, it is completely normal to feel frustrated, especially when you're facing really difficult symptoms or things aren't working the way that you had hoped. And so if you do notice some of that bubbling up, being able to just kind of take that deep breath, and like Dr. Deutsch said, trying to keep your tone calm and even, and then leading into these tips of how to even communicate assertively. So speaking from your experiences, using I statements. One of the first things about assertive communication is it's a lot more difficult for somebody to feel defensive when you're speaking from exactly what you are experiencing. So I am really scared of having procedures. I feel like this visit is going too fast. Very different from, oh my God, you're going too fast. Again, speaking from what you're experiencing in the room. Flowing into that, avoiding those statements of blame. So for example, you suggest all these treatments and nothing works. A way to put that a little bit more assertively would be, I'm really feeling frustrated. These treatments just don't seem to be working for me. Being honest and detailed. So it's a huge part of our culture to answer, how are you, with fine or I'm good. However, in a provider's office, fine or I'm good probably isn't what brought you in there, and it's not going to give your provider the information that they need to help you. So trying to avoid these vague answers and be really open about what you're experiencing, especially in a GI setting that can sometimes feel a little scary because we're talking about vulnerable topics like poop and diarrhea and gas. But really, the more your provider knows, the more information that they have, the better they're able to serve you. So giving those good detailed answers. So for example, actually, it's been a really rough month. For the past couple of weeks, I've had this pain in my abdomen. It feels like I'm being stabbed and it gets worse at night. It's a lot more information than it's been better.
And I think that that's a really important point too for our providers to take home as well, right? So even if somebody does walk in the door and say like, oh, I could be better, the next question from your provider would be, tell me more about that. Or what exactly do you mean by that? And allowing that door to open up to get more information, right? So asking more open-ended questions to understand a little bit more again about getting onto the same page. And similarly to what Dr. Foose mentioned about using your I statements and statements from personal experience, it's so much more meaningful, I think, as well, coming from our providers on using a little bit of reframing for how we talk about things in relation to healthcare as well, right? So, for example, Sally, who started medication P and just didn't have success with medication P, oftentimes what's written down in the chart was Sally failed medication P. That's just not true. Sally didn't fail anything. Unfortunately, medication P failed Sally. And so you see how very big of a difference it is in just the way that we use small phrases and terms, right? Another common example that I hear is, let's say I suggested medication A to somebody, and they come back 3 months later and I'm asking, well, how did it go with medication A? And they said, well, I just never took it. So again, I have to come back and say, so tell me what's going on, right? What happened with that medication? And so we can get onto the same page to understand oftentimes that I didn't explain well enough what was going to happen when they took medication A, or I was suggesting something that was simply not in line with their goals and priorities, right? Or for example, I suggested, let's say a low FODMAP diet, whereas our patient perhaps had a history of an eating disorder and was really afraid of that restriction and what it might do. And I didn't know that information at the time, right? So getting, again, more information to be on the same page allows us to communicate more effectively and assertively.
Yeah, and we're going to get into this more in this talk, but even just acknowledging those fears of medications and things as they arise and talking about it in the room. So often I work with patients who are prescribed medications, but then don't take them because they really didn't want another medication or they were afraid of side effects. And those were things that, had that been brought up in the room, then the provider or Dr. Deutsch, whoever that may be, could have handled that in the room. And we'll talk more about some of these pitfalls of just being afraid of upsetting a provider or having those conversations. But in general, just some tips for making a request. So starting some requests with a positive statement can really help to mitigate those potential defensive responses. And asking questions allows you and your provider to, again, play on that same team. So for example, I appreciate you looking into this. In the past, I was told SIBO might cause these symptoms. Is there any harm in running a breath test? Dr. Deutsch, do you have any more examples?
Yeah, absolutely. I had a patient, for example, last week who was fearful that they had a rare mitochondrial disorder that may present as some of the symptoms they were experiencing, and they were asking for a blood test to help to rule that out. Again, that's something that we discussed. We discussed what the symptoms would look like, and we were already planning to run some blood tests, and so adding on a new blood test as well is not going to be harmful for this patient and will provide a significant amount of peace of mind for her that it is most likely something that she does not have.
Mm-hmm. Yeah, and so
just to
yeah, go ahead.
Go ahead.
Say asking questions really helps to get both of you more information, whether it's, is there harm in doing this? What are the options that we have? Let's say you get those options from your provider. Okay, I really like the sound of this. Is that something we can order? So you can kind of see how there's almost this funneling of the types of questions of, what are my options? Or is there harm in running something like this? And then, okay, can we do that one specific thing?
Absolutely. And again, on the medical provider side of things, just remember, I'm making requests of you as a patient every single time I ask you to do something, even if that's just telling me what's going on. I'm requesting more information. I'm requesting you take a pill. I'm requesting you do a test. And unfortunately, these become so routine and day to day for us that I think we lose perspective sometimes on what those requests entail for our patients. And so I really try to take the time to actually explain what are the risks and benefits to a pill. What does a procedure entail? What will it look like from start to finish? And what are the results that we're expecting to find? And finally, what do we do with those results? So helping to provide all of that information, I think, allows us as the providers as well to improve how we're making requests from our patients. But, Dr. Foos, and perhaps you can tell me how you feel about this statement, but one of my favorite things that I like to tell patients, and I think resonates very well with them, is regarding shared decision making. So when I present a plan, let's say for SIBO, right, in this example, for my patients, I say, I get to be your GPS. I get to provide you with plan A. Maybe that plan A is Xifaxan antibiotic. Maybe plan B is dietary modifications. And maybe plan C is looking at other causes for that really yucky and uncomfortable bloating that you're feeling. Maybe it's abdominophrenic dyssynergia, and we should go ahead and think about doing PT. So there's lots of different options here. And maybe the first one has tolls and the second one is local route. And the third one is freeway. You can drive 75 miles an hour with no interruption. I think that the option with tolls might be the one that maybe is the most effective, but tell me what you're thinking. How do those feel for you, right? We always have the option to potentially change course if we hit a traffic jam. Maybe there's an accident on the toll route and we need to switch course. Absolutely. We have all of these things totally laid out in front of us. And so we have the option of switching back and forth between.
I love that metaphor so much, especially because using you as a GPS, but let's just say that somebody's using their GPS, even though it's their hometown. So they might say, okay, yeah, that road might seem like it's the most smooth, Dr. Deutsch, but actually, I know for a fact that at 4 o'clock at this time, there's going to be a traffic jam. And so that's where you providing more information really helps that GPS, the use of the GPS in this example.
Absolutely. So then what happens if you've asked for a test and the provider says no? Now what?
Yeah, good question. So acknowledging their message, okay, I hear you. I love the phrase, I hear you. It is a very magical phrase you can use, whether it's with a provider, with a loved one, really anytime, because it's letting that person know that what they have said has not only just like been physically heard, but it's being taken in. And so that tends to cut off some of that defensiveness at the knees. A lot of the times conversations will escalate when people feel like they're not being listened to. And so then asking some clarifying questions. So stating your need. I hear you. Help me understand why this test wouldn't be in my best interest. The goal is to engage in a conversation with your provider because there very well might be a good reason why they're saying no to that test. And if there's really not a good reason, then you can ask again. So I completely respect you don't want to run a test that you feel is unnecessary. But I feel I could really benefit from the information, even if it comes up with nothing. And I just messed it up saying that, but saying the word and as opposed to but, that takes a little bit of practice. But the word but tends to cross out anything that comes in front of it. So if I say, I respect you don't want to run a test you feel is unnecessary, but I feel this, sounds very different from I respect you don't want to run a test you feel is unnecessary, and I feel that I could benefit from this information. So just some extra tips and tricks with responding to no's.
Yeah, and remember again, like we mentioned right from the beginning, this is a team sport, right? We're playing on the same team, ultimately to make improvements in your health care. So while I might be firm in understanding that your diagnosis, let's say, is irritable bowel syndrome, sometimes having one additional piece of blood work or one image that you're looking for can really help to clarify some of your unsaid fears. But I'm never going to know that, right, unless we sort of have that open discussion to understand what are those fears. But ultimately, that's my responsibility to try to figure that out, right? So if I have Dr. Foos, for example, coming in with a diagnosis of IBS and she's telling me, but I think I need another colonoscopy, and having reviewed her records, let's say she's had 3 colonoscopies in each of the last 3 years, perhaps I can ask, you know, is there a way, like, what do you think we can answer? What information are you looking to obtain by having that additional colonoscopy this time around? And I may get some really valuable information there, right? She may tell me, well, my mother had a colonoscopy and people told her she didn't really need one. And then when she had it, she was diagnosed with this huge polyp and it was such a big deal and she had to have surgery and it was taken out and all of this other stuff, right? And say, thank you so much for sharing that with me. That's really, really helpful. You also had a colonoscopy last year and there was no polyps found, and the risk of those polyps growing in this very short period of time is very low. But I'm not taking that test off the table, right? Perhaps we can understand that if certain things happen, for example, you're experiencing new bleeding, new pain, you're anemic all of a sudden, or your bowel movements start to change again, that's definitely a topic that we should revisit. Maybe there's a different test that's less invasive or less potentially consequential on your health in terms of causing harm that we can run to help you answer your question, right? So there's a lot of work around and work with, so to speak, to avoid saying no, but to also avoid putting folks at harm for tests that may just not be necessary today, right? I say today, right? It's never to take anything off the table necessarily.
Okay, so the other way around.
So on the flip side to that, what if I've now made a suggestion for something and as the patient, you really don't want to do this, right? So we touched on this already very briefly, but I'll let Dr. Foos take it away.
Yeah, so again, Dr. Deutsch suggests this colonoscopy, and I'm terrified of colonoscopies. And so starting with my feelings and my experiences, you know, hey, again, I hear you. I am terrified. I really don't like procedures. And I want to avoid having one as much as I possibly can. What kind of options are there? Are there any other ways that we can get this information? So again, asking your options and stating what you need. You'll see kind of this very similar points throughout this presentation about asking questions and stating your needs. So I feel uncomfortable taking another medication. Is there another option we can try first? I really hate taking all these meds. I am terrified of having procedures done. Are there any other tests that we can do to rule this out? And I want to avoid this procedure.
Absolutely, absolutely. Again, as the medical provider, if I strongly feel that something is necessary to understand how things are playing out inside of your body, but that test doesn't feel comfortable with you, that's something that I need to work hard to explain, to educate, to walk you through what that might look like, or provide alternatives if it simply isn't fitting well. So when I find that my patients say no or don't follow through on my recommendation, that is a me problem. That is not a you problem. That is often because I haven't come up with a solution that is within your purview of how you conceptualize your healthcare. And so I need to be able to get on that level with you in order to help meet your goals and priorities. Again, I also tell my patients quite frequently that I am never here to twist your arm into doing something that just doesn't feel good, right? There is always a different way to approach how we can help to, again, improve your healthcare and the way that you're feeling. So I'm not here to make you feel yucky or uncomfortable. I'm here to help to make you feel better. So that said, you know, if my patient does decide that they in fact do not want to go ahead with a procedure, test, or treatment, we have to understand potentially what those consequences might indeed be, right? As we said, if having the procedure is the only way to know a definitive answer, we may not be able to truly answer a question if we can't obtain that information. If it's the best course of treatment, alternatives still may work, but we need to work on setting realistic goals and expectations together in that way, right? So certainly ask to engage in conversation fully so you can understand, again, on that GPS route, which of those pathways might be the ones that serve you best. And not every route is the same route for every patient or the best route for every patient. That's why we have multiple different options that exist to try to treat the same concerns or each person's own nuanced set of concerns.
Absolutely.
So we're going to just move into a conclusion here in terms of some strategies for appointments and some common pitfalls that we see as we wrap up. And again, I'll hand it back over to Dr. Fu.
Sure. So just some strategies for when you're going into appointments. So if as either the patient or the provider, you are feeling really frustrated or upset, or one of my patients put it to me this way, feeling a wrinkle inside throughout the visit, just some things to consider to include. So for one, writing down your questions or sending those questions to your provider ahead of time. In appointments, there oftentimes like things maybe go quickly, or you might be nervous and then you forget things. And so it's always really helpful to have these things ready in advance. Realigning the goals for care, bringing the conversation back to the subject at hand if it's gone off course. So if you find that you and your provider have gone down a rabbit hole and things, okay, wait, what were we even initially talking about? Let's go back to the issue at hand, this treatment, what's going on, etc. And then acknowledging where each of you are coming from. And if you're unable to reconcile those differences, being able to part ways on good terms. And so some common pitfalls that Dr. Deutsch and I often see from patients, and especially on my side of things as the psychologist, is I work with a lot of patients who are very afraid of annoying their providers or not wanting to make their providers upset with them. You know, saying things like, I don't want to message them too often. I don't want to call the office. I didn't want to say no to this medication, so I just didn't take it because I didn't want them to be mad at me, etc. Again, if Dr. Deutsch doesn't know what's going on or that you're not comfortable with this medication, that conversation and that team approach can't happen. And so the other thing patients come in a lot with is that fear that if I annoy my provider, if they're upset with me, then my care might be impacted, or maybe they're going to ignore me. And I can let Dr. Deutsch speak to that a little bit more, but I would say that's not going to happen. And really just, again, setting those expectations when it comes to what is the speed of treatment going to be, and when can you expect your provider to get back to you when you do communicate with them, especially now that we have these online mediums where people can message providers on their computer or on their cell phone. And so if you're noticing, okay, this treatment maybe isn't working the way I thought it was, checking in and saying, okay, is this how fast this is supposed to work? Is it supposed to be a couple of weeks? And then same thing, if your provider's not getting back to you and it's been just a day, that might just be a little bit fast. And so talking to your provider about what to expect in both cases.
Absolutely. And that's a really nice segue actually into one of the other online platforms that you'll be hearing during this session is actually really good tips and pearls and tricks and tidbits of wisdom on how to actually use that electronic health record to communicate with your providers. I think we touched on a little bit of it here, but Dr. Foos is totally right? I think it's that old adage of no news is good news. When I don't hear from you, I assume everything is going well, and I don't know if things aren't, right? Because you haven't told me, right? I unfortunately can't read minds. But on the total flip side to that is perhaps the patient that does call every day or sends a MyChart message every day, right? I have to be able to sit back and understand there's something going on here and we're not on the same page, right? We're not understanding each other. And the way that I tried to, again, reframe that, right? We talked a little bit about using our words slightly differently is I think unfortunately sometimes those patients become labeled as difficult, and I absolutely hate that terminology. There is no such thing as a difficult patient. There is a patient who is struggling in really difficult circumstances and looking for our guidance and our recommendations and our expertise, having studied medicine for many, many years. And so being patient and trying to help that person hopefully can be a unified, again, plan of care and goal. So with that said, I know we've run a little bit over time. I will leave both of our email addresses up here if you do have any questions. Thank you so much for joining us today. It was a pleasure to be able to speak with you all.
Yes, thank you.
All right, so I just wanted to, if we had a chance to sort of have a discussion with some of our advocates here, because so many of you have been through a lot in your healthcare. And so I know, for example, with me, I got finally in with a doctor that was going to help me, and I threw away 12 to 20 medicine bottles of prescriptions I filled that I didn't want, because I sat in the doctor's office saying, I don't want to try that. And it was, and at least they felt like I was really being bombarded and I didn't know how to say no. And eventually I said, okay. And I took my prescription, I got it filled, I got it home, I looked at it, and then it went on the top shelf. And then I go back a couple months later, yeah, I didn't take that. I really didn't want to take that type of medication. And it was, okay, well then we'll try this other brand of the same type of medication. And it was, for me, I didn't know how to stop and say, actually, doctor, I'm not going to take this, because it was just not within my skill set at the time. So it was great listening to these ladies give some examples of how I can say, I hear you, but this is not something I'm comfortable with. Are there other alternatives for me? A lot of these types of things I really appreciate. So Eric, Dr. Shaw, maybe you can kick us off with maybe some things that have really worked or not worked in your practice, with maybe a time when you didn't understand and then a patient said something. Some good ways that patients can do that.
Yeah, I think that Dr. Joyce, Dr. Fuss nailed it, that, when there's a lot of back and forth, there's usually something going on. So it might not be the thing that's actually being discussed in the moment, but there's usually something else going on. So, and trying to get at what that is, what really matters, and what's driving two sides. And there's really something that hasn't been discussed yet, and trying to unravel what that is. And it could be on either side, so it could be some hesitancy for some medical reason, or a cost reason, or concern that the provider has that maybe the patient doesn't have, or vice versa. So yeah, I think that that's one thing that comes out in the online patient portals. A lot of times, from the provider side, when there's a lot of back and forth, usually it takes a quick phone call. There's actually just something that over the phone, or more human interaction is able to solve. It's just hard to put into writing. Found that to be something, and that's something at the systems level. And maybe the doctor isn't the right person to answer this question. I don't know who is, because it's a big medical office. So that's where patients need the right providers and the right systems behind them, and the systems have to be really designed in a way that can help the patient. So sometimes that takes legislation.
Does anyone else have an experience you'd like to share with our extra audience? Sure, thank you.
I know my biggest issue with adding medications is it is not discussed the contraindications or the side effects. I can't tell you how many medications I've been prescribed that could have negatively impacted another condition, and the providers had absolutely zero clue to it. Thank God my pharmacists have caught it in time. It's been alarming, and we bring it up to certain providers, they just are very dismissive about it. I think that's something that really needs to be discussed, because they just kind of throw meds at us without even taking into consideration other conditions that we may have.
And again, going back to the presentation, this sounds like a great medication. Can we discuss the other medications I'm taking. Absolutely. And of course, you always have your other resources like your pharmacist to be able to get past that. And I know that so our next session here, really and truly, we're going to start diving into how do you really get that health care that you deserve and need in today's climate, right? So we're here today to go till tomorrow to advocate for change and ask lawmakers to enact new legislation that will make it easier for us to get the tests and the medications that we need in order to treat our chronic illness. However, that is not available today due to several different impending things caused by insurance companies and Medicare or all of those things. We're going to learn a little bit about that from now through the rest of the session. But first I'm going to talk to you a little bit about how this all came about. So earlier this year, I was actually asked to share my story, my patient illness experience. And I did that in this meeting. It was terrifying as I was on stage by myself, talking about myself. And as part of my patient journey, we talked about how I had spent decades suffering with my GI conditions, and finally had a doctor that gave me samples that worked for me. And then what happened is I got out of my samples, the actual hospital system the doctor was in says you can't do samples anymore. So she said, we'll write you a prescription, and it was denied. They said it's $900 a month. So I said, I can't afford that. And said, well, I guess I'll just go back to self-medicating, which is what I was doing before. So my doctor, who was great, and we talked about it when I finally said, oh, I didn't take that because I couldn't afford it. She says, let me do a pre-auth. And that got denied. And then she says, let me give you some copay cards. And my insurance also denied that. I'm not allowed to use that as long as I have insurance through them. So I am continuing to self-medicate. And that was 3 years ago, and I still self-medicate. I'm in the middle of giving my patient experience. I'm talking about this and what I go through, especially when I travel or if I have a flare. And after this talk, this sweet woman comes up to me and she says, so honey, did you ever thought about calling the pharmaceutical company and see if they have a patient access program? I said, well, what's a patient access program? And she informed me that if I had just taken a couple steps, I could have gotten my medication either reduced cost or free for all of that time. And I was mortified. I was mortified that here I am, Executive Director of IFFGD, trying to be helpful to patients, not just in America, but globally, to get the health care they need. And I was failing everyone because I didn't know. And so I came back after that experience, and I'm talking with the team at IFFGD, and we're talking about this and about all the hurdles that we have had, or our relatives, our friends have had in getting access to care. And all of a sudden we're realizing that, well, I'm not alone, you know, and that just within our small IFFGD family, everyone has a story of someone they know or something that's happened. And so we really wanted to dive into that. And so the entire team of IFFGD has spent the last 6 months really digging into how in the world do we navigate this system today. Because yes, tomorrow we're going to ask lawmakers to make change. But until they do, how can we help people? And so we're going to spend the rest of the day talking about that. But before we do, we wanted to share some of these stories that came from us as a team. And I know I just messed up the agenda, but that's okay, because I skipped forward to my portion of the agenda, which was to tell you what happened to me, and the fact that I had no idea that insurance companies could actually help you if you called them directly. Never crossed my mind. I work with pharmaceutical companies every day. Never thought to ask that question. And so as we go through the different options over the course of the afternoon, just remember that you always have to ask the question. But before I break bring Jamie Dumont, who is going to speak in just a minute. I want to tell you about Haley McCorkle. So she was on the agenda to speak today. She unfortunately could not make it due to a health reason that came up last minute. But today, she was supposed to be here, and she wasn't going to get here until really late, way after dinner last night. And the reason is because she had a family gathering in Charlotte. So she had actually driven from her home in South Carolina to North Carolina to go to the memorial service of one of her uncles. This particular uncle had pancreatic cancer and had gone through quite a few treatments. And there was one that was really keeping him alive. And the insurance company decided that there was a different medication that he should be taking. And they did what is called non-medical switching. And he was no longer allowed access to the medication that was keeping him alive. And we lost him. So she was leaving his memorial service to come here to help advocate against non-medical switching. And she was going to share, I'm sure, more of her story and more accurately and much better than I could. But that was her experience with these cost-shifting tactics that make us as patients have to pay or lose the things that we need to be able to maintain our health. So the third staff, person on staff at IFFGD who was willing to speak today actually is speaking on behalf of a family member. And so Jamie.
Just this microphone. So thank you everybody for allowing me to come up here and share the story. As Cecile said, it's not my story personally. It is for a family member of mine who asked me to share the story for her. As Cecile said, as we were all talking about what was going on with Cecile and different things, and Haley was talking about what was going on with her family members, I happened to be in a situation with a family member and thought, oh my gosh, here we are. There's 5 people who work at IFFGD, and 3 of us are coming up with these stories that are so similar. And as Cecile said, this story, this event was born from that and how to talk about it. So the message that I'm going to be giving is for one of our seniors in the IFFGD patient community, and she shared her story, so I'm going to read it so I don't leave out any of the important details or miss anything, because I do think it's very important, and I think it's something that certainly a couple of us in the room may be a little closer to than others, but still very important and hopeful that we're going to be able to see some change in the interim. So here's the story. My name is Dee, and I am over 65 years old. I am sharing my story about the challenges that I have experienced getting my medication after transitioning to Medicare. My husband and I worked hard to provide for our family and plan for our retirement. We are both on Medicare and live on a fixed income. We are not wealthy, but our needs are met. The cost of insurance and medical care has always been a financial impact. As we neared 65, I was getting excited by the prospect of moving to Medicare because I anticipated that it would make our lives easier and relieve some of our financial burden. I have GERD and asthma. You may not be aware, but these 2 disorders can often occur together, and each can exacerbate the symptoms of the other. I have prescription inhalers to both manage daily and to use in times of breathing distress. Unfortunately, they are either not covered by Medicare or over the allowance. As a result, the cost to maintain my prescription medications would average over $800 a month. This is my prescription medication only. When I realized this, I began researching options to get my medication without such a large monthly financial burden. I contacted my doctor, several pharmacies, and searched for online resources. I found the assistance programs offered by pharmaceutical companies, but unfortunately we were either above the income threshold or because we were on Medicare, we were automatically excluded from the programs. I became very concerned about whether or not I would be able to continue my treatments, So concerned that I talked to my doctor about getting the prescription to get my medications out of Canada. My doctor was not in support of that because those medications are not regulated the way that he felt that they should be. So I was discouraged to do that. I was discouraged by my findings, but I continued to look for options because, again, asthma inhalers are a very important thing to have. This is when I found that the price for same medication could vary greatly between different pharmacies. I also found that there were several discount prescription drug programs such as GoodRx, Single Care, and Blink that can lower the cost of each prescription. This finding was encouraging, but not without its own challenges. This month, the challenge is that programs and the cost continually change. This month, Harris Teeter may accept Blink and have the best price for my next month. But next month, they no longer accept the discount, and the cost of my medication could have doubled. Also, I have to go to different pharmacies to get each one of my different medications because, again, the prices are different at the pharmacies and what they might do. This discovery has led me to my current process. Every 2 weeks, I am online or on the phone checking each of my prescriptions at different pharmacies so I can find the most affordable option. I thought that moving to Medicare would make our lives better. We now pay 2 Medicare bills, 2 medical supplements, and 2 drug supplements. And then I still have to find a discount to lower my medicine's cost. This process creates stress and anxiety for me every month. What if I can't find the discount this month? What if I can't afford my medicine? I am sure that I am not the only one who finds himself in this situation. My heart goes out to those others that are in the same situation because what if they don't have the means or the ability that I do to check the different pharmacies or to know that there are discount programs that may or may not work this month? What do they do? Do they go without their medications, or do they spend the money on the medication because they have to have it in order to say breathe and take away from their retirement funds so at some point they're way below poverty level and unable to survive? There has been news coverage recently of recent legislation to help seniors with prescription costs. However, much more is needed, especially to assist seniors who are in the middle income bracket, because often they don't receive any of the prescription assistance programs, but soon having to pay for those prescriptions puts them much lower than that middle income bracket. Changes need to be made to help everyone that needs medication to be able to get it and afford it without the stress and financial burden that it can be caused. Thank you for listening to my story.
And thank you, Jamie, and her family member for sharing that story. Again, this is way too commonplace, and unfortunately, due to mandates around Medicare, a lot of the patient programs that we'll talk about today are just not available to those of you that are on Medicare or possibly Medicaid. So that's another thing for us to take to the Hill and advocate for, right? And so these are just some few examples just from our team of how these healthcare costs have increased and why we're here to try to talk about better access to care. But before we do that, a lot of what we talk about is insurance, right? So we've talked about finding the right insurance for me that's going to cover my medication because my insurance company didn't. I didn't know to look for that, probably why it was denied, right? And then, of course, talking about in Haley's case where, you know, her uncle's medication just got switched. That was through the insurance company. And when it's time to look at insurance companies, you know, you have options and you have ability to choose in many cases, whether it's through the healthcare marketplace where you can choose your insurance provider of care, or sometimes in workplace they'll give you a couple different options. And many times, I know for me, I never knew what to choose. It was looking at your coworker or your friend and saying, so what did you get? Oh, okay, I'll get that too. But understanding all the nuances that goes into insurance really is the base. And then we work from there with everything else. And so Alyssa Sutton, who is our programs associate at IFFGD, has done a lot of research about how to find a great insurance plan. And so she's going to come and she's going to talk to us about the things that you could be looking for for, some little pearls of information and things that you really need to think about before you make that selection. And Elisa?
Good afternoon. So as we have heard from all of these stories this afternoon, we can run into a lot of burdens when finding the healthcare that we need. And so one of the things that can help lessen these burdens is by finding an insurance plan that works for you. So the first thing you want to think about is, what type of plan are you getting? Ask yourselves the questions: does this plan make the most sense in terms of being cost effective? And does this actually meet my lifestyle needs? I'm going to show you two different types of plans that you can typically find on the healthcare marketplace. I chose these two because they are the most common that come with searching on the healthcare place and by getting them through your employer. So let's start comparing some of the pros and cons between getting these two different types. One's called a PPO and the other one's called the HMO plan. So with the PPO plan, you're typically going to have a larger provider network, which is going to allow you to see more healthcare providers. They're also typically going to cover your out-of-network providers and facilities. So if you're somebody that travels a lot, you have that freedom of being able to go to who you need to go to and still having that coverage behind you. Next is, a lot of times you will not need to see a primary care physician in order to be referred to a specialist. You can cut that middleman out, save yourself a lot of time and a lot of money that you're going to spend to see them. Sometimes you won't need to have a requirement for a primary care physician, so it gives you a lot of flexibility in terms of who you can see during your daily appointments. And also, with this flexibility, you're able to travel, right? That's great because you have that out-of-network coverage. You're able to have more providers that you can choose from. You're able to typically have that coverage nationwide and not just limited to your state, but you're going to have a higher out-of-pocket cost with this type of plan. So typically you're going to see higher co-payments, you may see a higher premium, you may have a high deductible. So these are just things to consider if this plan doesn't work for you, or if it does work for you based on your circumstances. The next is the HMO plan, which here you're typically going to have those lower costs. You're going to have a lower co-payment, you're going to have a lower premium, typically a low deductible, but now you don't have that flexibility. Now you're limited to a smaller network of providers. A lot of times these providers can be difficult to get into to see already. You're already waiting months to get appointments, especially if it's for a specialist. You don't want to run into a scenario where you finally get referred to somebody and they're not covered by your insurance company. Sorry. So now I want to talk about that list of providers that you can see. A lot of times your health insurance plan before signing up will allow you to check the list of providers and facilities that will be covered. Now consider the fact that you can find this information on those documents, but if you're somebody with insurance and you're still not sure of what your insurance provider covers, you can reach out to them or visit their website. They have to be very forthcoming with all of their information, and this allows you to know ahead of time who can be approved or denied. If you're somebody that already loves seeing your healthcare provider, you've built that great relationship with them, you don't want to lose them, but you're looking for a new insurance plan that may be cost effective or covers more things for you, you don't want to limit yourself to not being able to see that great provider anymore. So next we want to think about our premiums. Remember, the premiums are just what you're paying monthly in order just to have health care. A lot of times these premium costs do not go into your deductible and they don't go towards your out-of-pocket maximum. So make sure that it's affordable for you monthly. So now we think about that deductible. Now this is where patients can run into those surprise bills because you weren't aware of how much your deductible was and how much of it you needed to pay in order to get the care that you needed. Sometimes your insurance company can make you pay 100% of your deductible before you get full coverage, while other times you have something like a co-insurance plan, like an 80-20 plan, where you're only expected to pay 20% of the bill, and then your insurance provider pays the other 80%. And so it allows you to only pay a small percentage with or without your deductible being met. So talking about the copay and the co-insurance, remember your co-payments are going to be those standard rates that you're required to pay at certain facilities. So you may be asked to pay a certain amount to see a specialist, to visit an urgent care, or to go to an emergency department. Co-payments can become costly if you're visiting the emergency room all the time, or if you're somebody that does have to go to urgent care every weekend because that's when you're having your flare-ups and your doctor's office isn't open. So make sure you're aware of what your co-payments are. The next thing is your co-insurance, which I just did touch on a little bit, but this is where you're sharing the percentage of your bill with your insurance provider. I mentioned the 80-20 plan. There's also things like your 70-30 plan, where again, you're required to pay that small percentage. That insurance provider is going to cover the larger percentage, but you are sharing that bill with them. And last, I want to make sure that you are able to look at the prescription drugs that are listed on your formulary plan. In the United States alone, 17% of all of our healthcare spending is on prescription drugs, which is totaling us more than $370 billion per year. It exceeds all other countries. So looking at your drug formulary really can help you save a lot of time and money. So each insurance plan is going to have this list that you can view before you're able to sign up for that insurance. And they're also going to list for you any medical procedures or different tests that are also going to be covered. Your plan's formulary is typically going to be divided into 4 different tiers. Sometimes there's only 3 and some do have 4. It just depends on your insurance plan. But these drugs are typically divided by what type they are, whether they're generic, whether they are considered a preferred brand by your insurance plan, whether they are considered a non-preferred brand name drug, or whether they are a specialty drug. Drug coverage tiers can also divide one medication into different tiers based on how that drug is administered. So you may have something like an oral tablet that will appear in your lowest tier, where something like a solution is going to be in a higher tier and cost you more money. These coverage tiers are just a way to help patients be able to choose a more cost-effective option when possible. So here we have the drug coverage tiers. Notice the pyramid here. Your tier 1 is going to have the majority of the drugs that are going to be covered. These are going to be your least expensive drugs and the ones that are considered generic. Remember that your generic brand drug is the same as the brand name. It's just the only difference is the name on the bottle and really how much money you can save on it. Next, we have our tier 2 drugs, which are going to be your more expensive generic brands, and also the brand name drugs that your insurance plan has deemed as preferred. A lot of times this tier is where you're going to find your most affordable brand name options. Then we have our tier 3, which are your non-preferred brand name drugs. The drugs are typically going to be a higher out-of-pocket cost for you, so these ones do cost more money. And then finally, this is the most expensive tier. This one is going to cover all of your specialty drugs that cover all of your rare conditions and are going to cost you the most out of pocket. If you are somebody who already has insurance, but you've never seen your drug formulary because you didn't know to look for it, you can always call your insurance provider to get that information. If you're somebody like me, I did try to call my insurance provider because I had never seen my prescription list before. And I actually had to go one step further and contact my pharmacy vendor instead of just my insurance provider. They could not give me this information. Your pharmacy vendor is typically listed on your health insurance card, but if you can't find that information, your insurance company can tell you that as well. So why are people able to pay different amounts of money for the exact same medication? We're going to touch on this more in other presentations, but a lot of times these costs have been predetermined by the company before they're distributed out to the different variations of patients. If your government is the one that is the payer of your insurance, a lot of times discounts can be mandated, and so they will request that coupons and rebates by the pharmacies are given to the patients. If your insurance is the payer of the bill, they can require that, or they can negotiate those prices with the different companies to get them cheaper. A lot of times your employer, if you get your insurance through them, can also negotiate those prices. And finally, they have options where you can get discounts made freely through patient assistance programs, which we're going to talk to you about how you can qualify for those in a minute. But many pharmaceutical companies do offer these assistance to patients, so make sure you're aware if any exist. So you're probably wondering, how might these things affect you? You may fall into one of these patient categories, where you're somebody with a rare or a chronic disorder. You're already paying a catastrophic amount of money per year for your medical care, whether that be because you're seeing your specialist so often or because you have to take those emergency department visits. But it's important that you understand if you're going to get full coverage after meeting your deductible, because that may end up making you save a lot of money in the long run. Next, you may be somebody who has a family of small children or somebody that is looking to expand your family. If this may be the case, you want to make sure you're covered even under any surprise circumstances, especially for broken bones that end up in the ER. My 2-year-old daughter has already been to the ER 3 times. Not for broken bones, thankfully, but it gets costly. If you are somebody who travels a lot for either personal or professional reasons, you want to have that safety net of making sure that you're covered out of state. Now also, if you're somebody that has children 25 or younger that are still under your insurance, they may be out of state for college, they may be out of state visiting other family members. You want to make sure you choose a plan where they're covered no matter where they are. If you're somebody who never visits the doctor, maybe you have a very well-controlled condition, maybe you just go in for your annual visits, you don't want something with a high deductible where you have to pay 100% of your bill just to go see your doctor once a year. So you're going to want something that has more of that co-insurance, where you're only required to pay that small percentage of the bill instead of that large bill that we've all gotten and we've been very surprised by when we've gotten it. Whatever the circumstance may be, it's super important to make sure how this plan can affect the healthcare needs of yourself. And finally, I do want to leave you by making you aware that the Healthcare Marketplace open enrollment is from November 1st to December 15th. So if you are somebody that's looking for insurance, make sure you look for all of these things that we've talked about in this presentation today. Also, if by chance you've missed the opportunity to sign up during the open enrollment period, you can qualify under a special enrollment period, whether that be because you have lost a job that provided you coverage, maybe you've recently had a baby, gotten married, or have changed jobs where your household income has changed drastically. Just remember that you can always try to qualify, and the Affordable Care Act is there to try help getting you the affordable health care that you need. So if you guys have any questions, please feel free to reach out to us. We are more than happy to help any way that we possibly can. You can always email us or you can call us directly. Thank you.
Thank you, Alyssa. And I want you guys to know that you just, in about 15 minutes, heard hours and hours and hours of research. I don't know anyone that knows that much about insurance plans. So please feel free to ask questions. And if you at home have questions on anything that Alyssa said, you can contact us well. As you see on the screen, it's IFFGD at IFFGD.org. So we are running a little bit ahead. Hello, and welcome back from lunch here at IFFGD's Advocacy Event for 2022. For those of you at home, thank you for joining us again as we continue to explore the issues surrounding patient access programs for patients with chronic illness and how we can combat these today before we can have any relief in other ways. So tomorrow we'll be on the Hill, we'll be talking to lawmakers about different types of programs that can be put in place, bills that can be passed to help make our lives easier day to day to get the access that we need for our medical conditions. However, between now and then, there is things that we can do. There are things that we can do to take care of putting ourselves in a better place. It's just a matter of education. And so for the rest of this afternoon, we're going to talk more about those and how you can work with your insurance company or with other nonprofit organizations to get the access that you need for you. To start out this afternoon, we are going to welcome back, we are going to welcome Megan Che. Megan Che is a program assistant for IFFGD, and unfortunately, due to health reasons, was not able to join us. However, she is going to join us to give us her talk. Oh, I didn't realize you guys were going to see that. Hey, lady, you there?
Hi, yes I am.
Fantastic.
See if I can. Perfect.
All right, hold on one second.
All right. We starting with the appeals process?
The appeals process. We are.
We'll do.
And guys, I'm going to share our screen with Megan so she can see what you guys see. Technology is a fantastic thing. All right, do you guys see the right screen? Yes?
Yes.
And Megan, if you will just let me know when you need me to advance the slide, I'd be happy to do that.
Okay, we'll do.
Is it advancing?
No.
I did not break it.
I can't hear you now.
Okay, I apologize, but I have broken the remote, so I'm going to do it the old-fashioned way. Just let me know when you want me to advance.
There it goes.
Yes. All right, go ahead, Megan.
All right, so today we are going to be exploring the insurance appeals process if you find that your medication has been denied. You can go ahead to the next slide. All right, so if your insurance plan has denied coverage for your medication, there are some steps that you can take to challenge that denial. One option is going to be a one-time refill. And so this will allow you to talk to your healthcare provider and figure out the next steps without letting your medication coverage lapse. Next, you'll want to explore the possibility of other medication options with your healthcare provider, whether that be a generic version of your regular medication or looking for a new alternative altogether. If none of these steps prove successful, then it is time to appeal the decision with your insurance provider. You can go to the next slide. So the purpose of a first level appeal is to prove that your service meets the insurance guidelines and was rejected incorrectly. This can be done by either you or your healthcare provider contacting the insurance company to request that they reconsider the denial. Your doctor can also request a peer-to-peer insurance review. So a peer-to-peer insurance review is a scheduled phone conversation where your physician discusses the need for a specific procedure or medication with your insurance company's medical director. The goal of this is to obtain pre-authorization approval, or in this case, appeal a denial. You can go to the next slide. And so if the first level appeals prove unsuccessful, then it's time to move to the second level appeal. The goal of the second level appeal is to prove that the request should be accepted as it falls within the coverage guidelines. This typically happens by looking for another opinion within the insurance company. So one of the medical directors from your insurance company who was not involved in the initial claim review will be asked to look at the case and make a decision. You can go to the next slide. All right, and so if you have exhausted all of your options with the first and second level appeals, then you have the right to escalate and ask for an external review. In an external review, an independent reviewer with the insurance company, along with a doctor from the same specialty as you are being seen in, will assess your appeal and decide whether to approve or deny coverage. Next slide. And there are a few important things to keep in mind when embarking on this journey with your healthcare provider and insurance company. The first being that persistence is key. This is a process that you must go through with your healthcare provider, but you are the lead on this case. It will require lots of phone calls and emails to ensure you are staying on top of everything and following up with the insurance company and your doctor's office. Insurance companies often bet on people not following through with the process. They draw it out for a reason. Stick with it and don't be afraid to reach out for updates, questions, or any other concerns you might have. You'll also want to be prepared for this process to take time. Internal reviews can take anywhere from 72 hours to 30 days, and standard external reviews are typically decided no longer than 60 days after receiving the request. But keep in mind, these are just estimates and actual wait times can vary depending on your case and specific circumstances. You'll want to review your formulary as well. So a formulary is your covered drug list. You must take into account what is outlined within the formulary to find out if what you are asking for is within the guidelines of your coverage. If you are asking for something that is specifically noted as not being covered, then your appeal will be denied. Ask for proof and document everything. If your insurance company tells you your medication is not covered within the formulary, ask for proof. Have them show you where it specifically says you will not receive coverage for this service or medication. Make sure to hold on to all relevant documents, emails, and voicemails. Take notes during your calls and get the names of the agents you are working with. You want to have proof of your conversations in case you are given conflicting information. And lastly, don't be afraid to ask for help. Reach out to nonprofits that focus on your condition. Many of these groups, including IFFGD, are more than happy to write a letter of support to your insurance company on your behalf. The producers of your drug or supplies you are looking to get covered might also be willing to write a letter of support for you as well if you reach out. We know that the appeals process can be complicated and frustrating, but we hope that the information we've shared with you today can help make it a bit easier. And that is all.
Thank you, Megan. We so much appreciate you joining with us virtually today and for all the time that you put into preparing this PowerPoint and the research that you've done for that. Thank you, thank you.
Absolutely, I'm glad I could help.
All right, well, I appreciate you being here. We will not hear from you again this evening, will we? This afternoon? Or actually, you can.
Yeah. Do you want me to step in for the patient?
Absolutely.
Assistance program?
Absolutely.
Okay,
we will surely. Perfect. All right, so we will hear from Megan again a little bit later on.
All right.
All right. Bye, Megan.
We'll probably hear
Bye.
from her next, actually. She's actually going right now.
Really?
Yeah, she's next.
She's this one?
Yes.
I apologize.
Call her back.
Alyssa is a really fast talker. It is now time for your presentation. I'm just kidding. You're up next.
All right. Let me go ahead and get everything pulled up.
So next we will have with us both Alyssa Sutton and Megan Che. Alyssa and Megan work for the International Foundation for Gastrointestinal Disorders and are on the front lines of our patient interactions. Between the two of them, they respond to every email, every website contact, and every voicemail message that we receive as an organization. Through this, they have learned to work with patients and try to educate themselves as much as they can about ways to help people not only find doctors, find ways to pay for their services, medications, and send them valuable resources and education as well. Through this process, they've learned a lot, and so they're going to spend the next couple minutes sharing some information that they've learned about what you can do when the cost of your healthcare has gotten too high.
All right, so today Alyssa and I will be discussing your options for when medical costs are too high. If you go to get a prescription filled or go to schedule a procedure and find out it will cost you more than you are expecting, you are not obligated to buy or schedule at that time. If this happens to you, talk to your healthcare provider to see if there is a less expensive option, such as a different medication or a different location to have the procedure done. Also, ask them to double check the pre-authorization coding. Human errors exist and sometimes healthcare providers can make mistakes. If the incorrect code was put into the system, that could explain the unexpected high price. So what if you are outright denied coverage of your medication? Well, there are a few things that could have led to this denial. The first one being incomplete or incorrect paperwork. You want to make sure that your insurance company has all the paperwork that is required and that it has been filled out correctly by both you and your doctor. Sometimes denials can be due to incorrect insurance information being provided. Double check personal details, including birthdays and name spelling, with both your pharmacy and insurance company. You want that information to match the details provided on your prescription, or else you may not receive coverage for it. Next, you'll want to check to confirm that there were no coding errors. Different procedures and medications have codes associated with them. You want to make sure that these are filed correctly with your doctor's office and insurance company. Another issue could be a past due filing. Past due filings can lead to denials. Your doctor's office is required to file a claim within a certain number of days, or the insurance company won't cover it. The insurance company will be able to tell you if this was done late or incorrectly. And lastly, sometimes you are required to pay full price until you have met your deductible. Different policies have different requirements, so knowing your plan and the specific administrative details associated with it can help cut down on time spent researching when you receive a denial.
So next, you're going to want to find out if this medication is listed on your formulary. This is something that we've talked about before in previous talks. Remember that this is your list of drugs that are going to be covered by your insurance. If it is not on your formulary, this may be that your health provider needs to ask for a formulary exception. This exception can allow your insurance company to still cover the medication without it actually being listed on your plan's formulary. A health plan should have a form on their website, or you can always ask them to send you one for your healthcare provider to send in the request. It may also require that your healthcare provider write a written statement that talks about why this medication is necessary for you. It is also possible that your plan will only cover the generic version instead of the brand name medication. Generic medications are the same, they are just as effective. They'll just save you money in the long run if you are able to use that as a substitute for the brand name medication. And sometimes your medication can be turned into something called a compounded medication. This is where you either combine different drugs or alter the ingredients of the drugs in order for it to best meet the needs of the patient. Sometimes these compounded medications can be covered under different medical benefits of your insurance plan. Now let's talk about if the drug is listed on your health plan's formulary, but for some reason is still being denied that coverage. So first, find out if you need something called a prior authorization. These authorizations need to be completed by your healthcare provider, and they can sometimes take up to 72 hours before they become approved. Now, you are able to get something called an emergency fill of the medication, which will give you a short supply of either 10 to 15 days. And your healthcare provider can also send in an emergency request for that to be reviewed within 24 hours. Some health plans will make you resubmit these requests, and so even though it has been approved, keep in mind that your healthcare provider may need to resubmit it periodically throughout the year. This type of issue can be seen with things like a brand new drug that maybe hasn't been around long enough. Your insurance company won't deem that as being the preferred diagnostic or preferred medical procedure for your condition. So you can always talk to your healthcare provider if something like this can be appealed. Next, think about step therapy, right? That may be coming into play here. So this is going to require that your healthcare provider show that you have not only tried separate medications that are listed on your formulary, but you have failed at taking them, or those medications have failed you. Now that being said, remember that these types of things can be appealed. You can ask, and your healthcare provider can show that taking other medications are not effective for you. Maybe because of side effects, maybe because you've tried them and you did not react well to them. Whatever the reason may be, you can always appeal that process. Next, your insurance company may not find your care as deemed as necessary or appropriate based on your condition or diagnosis. And finally, that care can be viewed as either experimental or investigational. This can happen either because it has not been given full FDA approval or because not enough healthcare providers have established this type of treatment as being safe and effective. For both of these things, actually all three of these things, remember that there is that appeals process, and you can always make sure that your healthcare provider can help assist you in making sure that you can gain the medications that you deserve and need. Other options is that you can actually ask for something called a cash pay option. I didn't know that this existed. This is something that you have to ask for when you go into your pharmacy. Several states have something called a gag clause, and what this means is that your pharmacy rep cannot voluntarily tell you that you may get the medication cheaper by not filing through your insurance. So if this is an option for you, make sure when you go to get that prescription filled, you ask for that cash pay option because it may end up saving you money. Some organizations also offer prescription discount cards. These are cards that can really help lower the cost of your medication from anywhere from 80 to 90% below the total cost or the original cost. And finally, check to see if a pharmaceutical company that developed the drug has any patient assistance programs that can help. Your healthcare provider may also be aware of some of these programs, so you can always ask them for assistance with this as well. And Megan's actually going to talk to you about these programs right now.
These programs
you have any questions, please feel free to reach out to us, as we'd be glad to answer any questions that you have.
Thank you, ladies. We really appreciate you joining us again, Megan, and I believe now we will say adieu. Bye. All right. Should I call it one more time? So now that we have talked about programs that could be offered through the actual pharmaceutical companies themselves, we mentioned that they aren't the only ones out there trying to help. There are some nonprofit organizations and other groups that are trying to make a difference in this area. We have spoken to quite a few of them, but we are going to give 2 examples today of nonprofit organizations that IFFGD has worked with that are trying to help with people in being able to afford their health care. And Alyssa's going to tell us about those 2.
So I was able to sit down with different nonprofits, as Cecile had already mentioned. I chose these 2 to highlight because I thought that they would be able to help you in terms of saving the most money for your health care. So the first organization is called Needy Meds. They are a nonprofit organization that really just is there to help you find assistance for any of your medical needs. In the event, as Megan has already mentioned, it's really important to remember that your most cost-effective option is to always go through the pharmaceutical company first. So when we talk about these nonprofits, make sure that you try to contact who developed the drug before you reach out to Needy Meds. Really, Needy Meds can help make it easier for you to find different types of assistance. You can find programs by searching for the name of your drug. Their database is going to be there to cipher through over 400 different patient assistance programs that are provided by either a pharmaceutical company or other nonprofits or government agencies. Now, their database is regularly updated in order to make sure that these are still available to you. So if by chance you sign on and you search for that drug but you don't see any programs available, it's always great to check back up to see if one had been added. Now, also, they have something called a discount card in a $4 generic drug program, which I'll touch a little bit more details on in a second. Their website also will allow you to search for things like sliding scale clinics. If you've never heard of these, this is where they're typically going to base your medical fees off of your income. And so they have reduced costs. This can be either for dental or medical. Sometimes it's for mental health clinics, and sometimes it's for substance abuse clinics. And in addition, they can also help you find transportation services if you are somebody that struggles to get to your appointments or somebody that needs medical care in another state or country. So this is an image that I wanted to show you just how easy it was to search for the drug. They have a search bar up to the left where you can just type in that name, or you can search for that drug alphabetically. Once you have searched for that generic medication or brand name medication, you're going to see different icons come up that are showing what is available to you. This first icon highlights all of the patient assistance programs that are available. The next tells you about any of the $4 generic programs, which are just pharmacy retailers that are offering different discounts. The next one will give you any coupons and rebates that you can get. The fourth gives you support pages. There may also be a video of the drug and any additional information that the pharmaceutical company wanted to make you aware of. If a pharmaceutical program for patient assistance comes up, it'll typically look something like this. I actually searched this based off of the drug rifaximin, which is a drug for IBS-D. It's a high-priced drug, so if you're somebody that does take this, they do offer patient assistance programs for those as well. They provide all of the information that you need right there in order to apply, but if by chance you still have questions, feel free to always reach back out to Needy Meds and ask them anything, because they're there to help any way that they can. As I mentioned before, Needy Meds also has a discount drug card. I think this is really great because it can lower your costs up to 80%. It is free and it is anonymous. So if you have one card, it can be used by all the members of your family. They don't track anything. You don't need to enroll. You don't need to register. The only thing that Needy Meds is going to track is how much money they were able to help different patients save. And these cards are accepted at over 65,000 pharmacies, but if by chance you want to just make sure, you can always call your pharmacy ahead of time before you get your prescription filled to make sure that they do accept that card. And this card is also not combined with your insurance, which could be a good and a bad thing depending. If you think about that cash pay option that I talked about in our previous talk, if it's cheaper for you to not file through your insurance, then you can use this card and get that drug for even cheaper. Next, I wanted to highlight their $4 drug generic program. Now it says $4, but I do caution you that this was made a long, long time ago when you would typically still see and be able to access medications at a very low cost. Nowadays, you'll probably see the cost range anywhere from $4 to about $30. And really, you can see these for 30-day supplies, 60-day supplies, 90-day supplies. These programs just make it possible for you to access medications in case you're struggling to pay. And they do offer over 3,000 coupons and rebates. And as I mentioned, it's not only, why Needy Meds is great is not only just for healthcare, but they also have a COVID-19 center. A lot of us have been impacted by the COVID-19 pandemic, and there are different organizations that really do want to help you, whether it be because of your diagnosis or because of another financial hardship that you may have struggled with. Most of these types of programs for assistance will have eligibility requirements, either based on a diagnosis or based on your income, but it is not just limited to those with a diagnosis. And this actually was advice from their patients on the Needy Meds website that I thought would be helpful to you. So when you're somebody that's searching for a different program for assistance, make sure that these programs are covering the drug that you need. Sometimes there can be a limitation on the dosage. So your doctor may want you to take a very specific dosage, but this program is offering it either too low or too high of a dosage that you cannot take. So make sure you're aware of any dosage restrictions. Next, some of these programs are very limited to where you live. So make sure that you search your residential area to see if that may cause a conflict with being approved for the program. And also, some of these programs are only offered to people that don't have insurance, and not just for those that are underinsured. So make sure you look for those specific details as well. Some programs some programs require an enrollment fee. And sometimes that fee doesn't outweigh the benefit of getting that drug at a lower cost. So make sure you're aware of those enrollment fees as well. Review the drug discount list frequently. As we know, pharmaceutical companies can lose their patent, so generic brands are readily available, and they're readily available all the time. So if you don't see your drug having a generic option, make sure you always keep updated to see if that becomes available. And next, there is something called a pharmacy price matching, and you can always ask your pharmacy if that is something they can do. They'll match the cash price of the medication if you find it cheaper at another pharmacy. Make sure you save those receipts though on how much that costs, and make sure you come in with the information of how to contact that other pharmaceutical company, the other pharmacy, because they're going to want to verify that that medication was in fact cheaper. This is just an image of part of their website. This has all the things that I listed and talked about today. So it's just right underneath their healthcare savings tab. You can find your COVID-19 center there. You can find the generic drug programs there, your discount card, everything that you need. And I don't know if I mentioned this, but their discount drug card is available for downloading on their website. So you can always download it right from there. The next nonprofit that I wanted to talk about is something called RX Outreach. This is a licensed nonprofit mail-in pharmacy. They offer over 1,000 medication strengths that cover most of your chronic diseases, but not all. One of the most important things is that even though this is a pharmacy, you can't schedule any virtual appointments with them or have them have them write you a prescription. They are there to fill your prescription. This pharmacy can ship directly to your healthcare provider's office or directly to your home, whatever is most convenient for you. They also will give you more of a convenience by either offering to send you just a 30-day supply or a 180-day supply, so that you don't need to worry about getting that medication filled. Most of these medications are offered at a 70 to 90% discount. This is thanks to different pharmaceutical companies that have either donated their drug in money or by different fundraising efforts that have been done by RX Outreach throughout the year. The other great thing is that their shipping is included in their costs that you're going to see online, so you're not going to have anything unexpected to worry about in terms of money. There are no hidden fees there. RX Outreach does typically offer free medications. These medications can rotate monthly, so it's always good to check. I know right now, I just checked the other day, they have about 25 different options for free medications. And these, like I said, rotate. So if you don't see one on there this month, there may be another one next month that comes up. It's important to also remember that they only cover those medications that people are going to take long term. So you're not going to find any of the acute medications on this pharmacy. And then finally, if the medication that you take is not listed, but you are somebody that does take a long-term medication for a chronic disorder, you can call their number in order to request that medication become available, and they can always review your request and see if it can in fact be made available to you and other patients. So this, I just showed an image so you could see how easy it was to search for those $0 drugs. All you have to do is type $0 into the search bar and you're going to get all the options. I took a screenshot of just 4 of the 25 different choices that you can see, but it does allow you to see the dosage ahead of time so that you know what to expect. And instead of searching for specific medications, they do also have a PDF list that is currently being updated, so I actually don't have access to it right now, but they will list the drugs based on the type of disorder that you have or type of disease. So these were all of the ones that were listed for gastrointestinal disorders, but they do also update this regularly and are currently updating it, so this may change. And finally, again, if you have any questions, feel free to reach out to us as we will be able to help any way that we can.
Thank you, Alyssa. We appreciate all of the research that you have done to really learn about these different options for patients, and then for explaining them so wonderfully to us today. So that ends the educational part of our program. I did want to take a little time to have some discussion, especially around some of these issues that people might have around the step therapy, the copay accumulators, as well as any other types of issues. We heard today about Medicare not being, having the freedom to be able to take on some things like copay cards and other cost savings that other patients might be able to take advantage of, and just all sorts of there are other types of things that might be plaguing people today in different types of cost shifting tactics, as we like to call them. So if anyone has something they want to share, an experience they've been through, we'd love to hear from you. Anyone? Up. Okay, so I learned this from today. I'm a Medicare patient, so most of my medications aren't covered by Medicare, or if I wanted the drug coverage cost, I wouldn't meet my deductible for the ones that are covered, because those are the cheap ones. So Alyssa's discussion today really helped me, because I saw on her list, and we talked earlier, that there are a lot of medications that gastroparesis patients in particular struggle with getting that are on those RX outreach and meeting meds that I don't think any of us ever knew about. I didn't think. So I'm definitely going to go share that information. That's what I have. No, thank you. Thank you. Thank you very much. John?
Just to add briefly to that, I just was started on a new medication a month and a half ago or so, and it was going to be like $270 out of pocket. With Medicare, again, we thought we couldn't use the copay cards, but I did call and talk to the drug company. And since I my insurance was probably through Medicare, they were still able to help me, but it had to be mail order. So I think that's kind of what we were discussing. I just wanted to share
Yes.
a piece where it does work that way.
So again, as I think Alyssa said 3 times, between Alyssa and Megan, always call the pharmaceutical company first, because they truly know all the best routes to get the best discounts for you to be able to afford your medication. And then of course there are other options. And these